I'm so excited to be here. So I came to this meeting when it first got started, and I was first getting started. I was just like fresh new faculty and really excited to be working in this space of aging with HIV. And I loved this workshop, still do, because it truly is a workshop. It's small, it's single track, people think, people push each other. And I think out of these meetings, we come up with new ideas, we come up with new ways forward. So I'm very excited to be here. I'm dealing with a little bit of a cold, but I promise my voice will hold out. So I'm happy to be here, and we'll sit here and think for a few more minutes about where we've come from in the last 10 years, but also think about where we're going, because I think there are some important population influences that are coming down the pike, which we as researchers focused on aging with HIV need to be aware of and need to be working towards. Oh, perfect. So I do have a few disclosures I wanted to make you all aware of. So first, I'm going to use the US as an example of the shifting age distribution of people with HIV. We have these data from the Centers for Disease Control and Prevention, who capture all of the US HIV data. And note that the US has had access to effective treatment since its advent, so the US is kind of on the leading edge of that shifting age distribution. Countries with later rollout of ART may currently have younger distributions, but they won't for long. So here I'm using the US as an example of what is for some countries and what is to come for other countries. Of course, we know that the underlying age distribution of people with HIV is shifting, it's getting older, but how many people with HIV are over the age of 65? In the United States, it's 80,000. 80,000 of about 1 million people diagnosed with HIV were 65 or older in 2016. That's 8%. And 80,000 is nearly double the 45,000 adults with HIV who were 65 and older from just 4 years prior in 2012. So that right tail of the age distribution of people living with HIV is thickening very fast by approximately 1 percentage point per year. So within the population of people with HIV, there are lots of subgroups. Subgroups with differential exposure to primarily timing and type of effective HIV treatment. When we remember that HIV incidence has been the highest in adults 30 and under for many, many years, we know that many of the adults at these older ages have been living with HIV for a long time, likely started treatment with lower CD4 counts, and perhaps were exposed to more toxic antiretrovirals. Also in these older aged individuals, there are new infections. We can't forget about that. They are a much smaller proportion, but they are there. Approximately 900 new diagnoses of HIV infections occur among adults 65 and older in the US every year. In the younger parts of this age distribution, we have individuals who were more likely to initiate ART at higher CD4 counts, had less exposure or no exposure to those earlier, more toxic ARTs. So there's a group of people here at the younger ages who are getting that earlier treatment, perhaps less toxic treatment, but in addition, there are also individuals who are presenting late in those younger ages, primarily due to stigma and other barriers. And we'll see how the demographics of people who are most impacted by stigma help shape some of that, or explain a lot of the shape of that younger distribution. So being an epidemiologist by training, there is nothing more that I love than a 2x2 table that provides some clarity on these really complex topics when you're talking about a whole population. So this is how my brain works. I stratify by current age, right, thinking about people living with HIV today, and I also stratify by prior exposure to ART, the timing, and the type. And then I distort the table, right? Distort it so that the cell sizes are more reflective of the sizes of these groups within the population, just to bring in a little bit more of that context as we pursue our research in individuals with HIV. So let's get started with looking at the current unmet needs of the adults who are currently older with HIV, who initiated treatment, oftentimes at lower CD4 counts with those earlier, more toxic ARVs. So I'm a scientist without the skill set to care for older adults with HIV directly. So I love the fact that Dr. Freed just said, I see it. I can see frailty, right? I know it when I see it. I turn to a lot of pictures when I'm thinking through who is in my data. And this amazing article from the New York Magazine, which now has aged itself, this was 10 years ago already, that this article came out highlighting individuals who were older with HIV. And I find these pictures very convincing. To me, these individuals look, and in the article it described how they felt, much older than their chronological age. It also reminds me that in this distribution of persons with HIV, it is a very heterogeneous population. If you look by gender, if you look at race, if you think through different types of HIV acquisition risk, it is a whole composition of a bunch of subpopulations, all of which whom have unique characteristics to risk profiles for health outcomes later in life. So heterogeneity in these subpopulations that compose the overall population of people living with HIV is a shared feature of a lot of epidemics all over the world, a lot of HIV epidemics all over the world. It's not just specific to the US. So the majority of older individuals with HIV experience changing treatment guidelines over the course of the last 2 decades. They're highlighted here in yellow. And as the toxicity of the regimens declined, the CD4 count at ART initiation increased and eventually was removed altogether in the treat all era, which occurred in the US in 2012. Those who initiated treatment at lower CD4 counts also experienced longer durations of immune activation and inflammation from the replicating virus itself. And some of the earlier antiretroviral agents were known to impact mitochondrial function and have metabolic consequences. We cannot change those exposures. Those exposures occurred, we cannot change them. That uncontrolled viremia, the lower CD4 counts at ART initiation, the more toxic ARVs, among whom our older individuals were more likely to have experienced. But we do have to consider all of those exposures when we decide how to best care for these individuals with HIV and when we generate the evidence body to inform that kind of care. In the past decade, we've had many, many studies, some first presented here, that have looked at comorbidities individually, but also multimorbidity among adults with HIV. A lot of the populations from which these data come are those individuals who are aging with HIV. They are the individuals who initiated treatments at lower CD4 counts. There's clearly an increased burden of multimorbidity in adults with HIV, and it is global. I have not yet seen any data to suggest a plateau or a decrease in this multimorbidity burden. The causes of the morbidity in older persons with HIV are many, but cardiovascular disease and its precursors, as well as cancer, have had particularly important burdens amongst older adults with HIV. And I think cancer is kind of an interesting story, right? It's been a part of the HIV story since the very beginning. 3 cancers, type-specific cancers, are still AIDS-defining illnesses, but the epidemiology of cancer and HIV has evolved. The burden of lung cancer in people with HIV has stimulated numerous investigations to better understand the mechanism, and more research is needed to better understand treatment, screening, prevention. Subclinical, mild, and HIV-associated neurocognitive disorder inflicts a large burden on adults with HIV, particularly these subclinical and mild cognitive impairment statuses. Mental health conditions are of great burden, as is substance use, and of course these mental health conditions are can become a part of a vicious cycle with physical comorbidities as well. Co-infections are also present, we can't forget about those, oftentimes acting as an accelerant to other physical disease outcomes. So many older adults with HIV have long-standing, trusting relationships with their healthcare providers or clinics that have served as their healthcare home for very long periods of time. With the mounting burden of multimorbidity, the role of the healthcare home does require many more resources. And as a recent article warned, the resource that is projected to be in the shortest supply, while the population of older adults with HIV continues to grow, are the infectious disease trained clinicians themselves. Further, the disease-specific screening and treatment guidelines can be overwhelming for anyone with multimorbidity, including people with HIV. Cynthia Boyd, a geriatrician, made a powerful point, first in JAMA and then for this article in Current Opinions of HIV/AIDS, where she depicted a day in the life of an older woman without HIV, following every disease-specific prevention, screening, and treatment guideline. This day looks virtually impossible. It does not all fit on one slide. We barely made it to lunch. And I think about the idea of living with this on a routine basis and an older woman without HIV. And then we think through what that would be like for somebody with HIV. And we layer on another potential layer of clinical treatment guidelines. Here we see that although adults with HIV may need additional focus for prevention and screening and treatment, either adding HIV-specific guidelines or adding HIV to general population guidelines are kind of our two pathways that we could go. Perhaps we should be taking the approach of integrating HIV as a risk factor into disease-specific guidelines for the general population as opposed to creating completely separate guidelines for HIV-infected individuals, but that only is possible if we know that there are no differences between what is needed for screening and prevention and treatment between HIV-infected and uninfected adults. That's not the case here with atherosclerotic cardiovascular disease. We know those risk prediction models are not as well calibrated in persons with HIV. So we do have a number of situations where HIV-specific guidelines have to be put forward. I hear from my clinical colleagues that the task of applying every disease-specific guideline to care for a person with HIV often morphs from virtually impossible to completely impossible when you impact that huge demand with the social determinants of health that are disproportionate in persons with HIV, including lower socioeconomic position, greater exposure to stigma, and structural barriers that are oftentimes based on gender and race. So what do we do? How do we best help adults with HIV? What additional research is needed? Continuing to push beyond the research of single comorbidities and into that space where we have measurements from the field of geriatrics informing what we're seeing is where we need to continue to go. For example, mobility. The max men showed that men with HIV were slowing faster than the max men without HIV. Gait speed of less than 1 meter per second is a threshold for defining disability. And as you can see here, gait speed is differentiated by HIV status beginning as early as age 40 when the curves start to split. Mobility can be a serious barrier to care among persons with HIV, which can result in numerous negative health outcomes. Social isolation, defined as a lack of contact and social support between an individual and other people, influences both mental and physical comorbidities. And there's a disproportionate burden of social isolation in people with HIV, perhaps due to the disproportionate burden of conditions linked as mechanisms to social isolation. So the geriatrics literature is much more rich with examples of the role of social isolation on health outcomes, which we can learn from and modify to potentially prevent these negative outcomes among our older adults with HIV. And we know that falls in the general population can be that tipping point from which a human cannot necessarily rebound, doesn't have the resiliency to recover, leading to numerous negative outcomes, including death. A recent study in the WISE showed a 32% increase in the risk of first fracture in women compared to women without HIV. And frailty, interestingly, was an independent risk factor for fracture amongst that population as well. Among people with HIV, predictors of fall include low physical activity, detectable viral load, efavirenz use, other non-HIV medications, including medications for diabetes and depression. The VAX drilled down a little bit deeper into the non-ART medication use and falls relationship and found people with HIV who were prescribed benzodiazepines, muscle relaxants, opioids, and had and/or had hazardous alcohol or illicit substance use had a greater odds of falling in a case control study. The research thus far on falls has clearly demonstrated the burden, but continuing to understand the predictors of falls and effective interventions will push this science forward to prevent falls and the subsequent negative health outcomes among adults with HIV. And polypharmacy. So as comorbid conditions accumulate, often non-ART medications do as well. And we see data from the VAX and the MAX studies that polypharmacy burden is greater in adults with HIV even after omitting ARTs themselves from the definition of polypharmacy. An intriguing study from Uganda reported 15% of adults with HIV were taking 4 or more non-HIV medications or supplements. So the accessibility and the use of supplements varies dramatically across the globe, and we really need to start considering that in a lot of our research on polypharmacy, even though those things can be very hard to measure. Polypharmacy has been linked to an increased risk of death. And so in 2013, the VAX offered up this model to optimize medication prescribing among adults with HIV and polypharmacy. And this roadmap of how to approach polypharmacy starts with the complete reconciliation of medication. It includes assessment for tobacco, alcohol, and other substance use. And it ends with a patient-centered plan. I have yet to see studies that provide the details as to how to best implement a model just like this. And as I learned earlier this month at an NIH-sponsored workshop about aging with HIV, there really is a critical role here for implementation science in understanding how to get the right intervention to the right person at the right time. But I think this model is one more step on the pathway to changes in how we care for those who are currently older with HIV and likely experience that longer duration of viremia prior to ART initiation and perhaps exposure to more toxic ARTs. So at that meeting that I just referenced, Christine Erlandson made a comment about the geriatric 5 M's. So this is a model, this model is a patient-centered approach to addressing flagship geriatric concepts of mind, mobility, medications, and multimorbidity within this context of a complex biopsychosocial setting in which people live. It would be fascinating to see a randomized trial of the 5 M's versus current models of care among older adults with HIV to see if these different approaches could improve the quality, not just the quantity, of life. Before we move on to factors that may influence the future burden of comorbidities among those who are currently younger and will be aging with HIV in our future, let's focus for 1 second on this group of older individuals with new HIV infections who are initiating treatment likely at higher CD4 counts in this treat-all era with less toxic ARVs. So first, it's important to know that in 2017, 2% of the new HIV diagnoses were occurring in the US were occurring among those ages 50 and older, according to CDC surveillance data. And among those age 50 and older with those new diagnoses, the majority were occurring in men who have sex with men, 28% were occurring in women, and among women, the vast majority had heterosexual transmission and acquisition risk. We need to know more about the aging trajectories of these adults who acquire HIV at older ages, but oftentimes they're excluded in our studies because we are looking at individuals who have been aging with HIV. Additionally, it's about 900 people a year. These individuals are quite hard to find in a lot of our studies. Beyond that, I think the most compelling part of the numbers of new diagnoses among older individuals with HIV should cause us all to take a moment and think about what guidelines say about testing. And right now, guidelines don't necessarily say much about testing among individuals over the age of 65. But clearly, there are infections happening there, and as this age distribution continues to push up into those older ages, when prevalence increases, incidence is never far behind. Speaking of incidence, when we look at the suppression rates among those older individuals with HIV, we see 60% were virally suppressed in 2017. 40% were unsuppressed, which actually really surprised me. And I think that this is another reason we need to continue to focus on those older individuals who are newly infected with HIV, and better ways for us to think about testing in the population greater than 65. Moving to the group of individuals who are initiating ART earlier in their HIV disease process in this treat-all era, and hopefully using less toxic ARVs. The pressing question for this group is, will the burden of morbidity change if ART initiation occurs predominantly among younger individuals earlier in their HIV disease process and with ARVs that are less toxic? So that's a loaded question that makes 3 huge assumptions. So let's first just make sure we have data to support that those 3 things are actually occurring, and we'll start with predominantly younger individuals initiating ART. So with funding from the National Institutes of Aging, my team and I have recently developed a model to project the age distribution of all persons with HIV. One of the parameters that goes into that are the individuals who are initiating ART. So here you see, I'll show you a total of 15 different subpopulations. Again, I'm a big fan of recognizing the subpopulations for who they are and how they contribute. We used data from the NIH Accord, observed estimates of ART initiators, and we used estimates of new diagnoses from the CDC to create these projections. Our observed data came from 2009 to 2015, which does include that switch to the treat-all era in 2012, and we project forward to the year 2030. Here we see the age distribution in 5-year intervals. Each line is a 5-year period. The darker one is 2010, the lighter ones are 2030. And we can see the projections of the age distribution at ART initiation. It is shifting to younger ages among MSM across these different races. But when we put the full picture up there, it isn't shifting as quickly for all the subgroups. So we need to be very alert to this and focused on this idea, and we need to be sure that the age at ART initiation is tracking very closely with age at HIV diagnosis to ensure we are linking people quickly to care. We also see that in the treat-all era, this idea that individuals are initiating at higher CD4 counts is ringing true. We did see that bump. These are data from the NIH Accord looking at CD4 count at ART initiation. But notice we've kind of hit a ceiling, and we hit it pretty quick after that 2012 bump. So I'm hopeful with the ending the HIV epidemic initiatives, with more test and treat initiatives, we'll see another increase in CD4 count at ART initiation, but I think we have to be realistic that there's going to be a ceiling there as well. So yes, individuals are initiating at higher CD4 counts. We don't have guidelines restricting initiation to lower CD4 counts, but it's not necessarily going to be a CD4 count at ART initiation in everyone who's initiating that would rival that of a person without HIV. And then let's talk about ARVs and the idea of less toxic ARVs. That's also another loaded area. Recently, there has been a lot of research and investigation about weight increase after integrase inhibitor initiation. And this is guideline recommended. Individuals initiating ART should be starting on integrase inhibitors. So this weight increase caused a lot of alarm, as it should. And my question was, okay, there's a weight increase after ART initiation, which wasn't necessarily something that we didn't see before integrase inhibitors. We started to see among individuals with integrase inhibitors, maybe this weight gain is a little more pronounced. But to me, the next important question was still, so what, right? What does this mean? What is this translating into? So in an analysis presented last week at ID Week, Peter Ribeiro and John Curtis showed that there was a 50% increase in the risk of incident diabetes among those initiating ART with raltegravir in the NIH Accord. So we do need to be really conservative about this hypothesis that individuals are initiating ARVs with less toxic regimens. They are not as toxic as D drugs, but we have to be vigilant. We have to continue to watch as individuals initiate treatment. We have to continue to look within existing populations that include the gamut of persons with HIV, including women of color, including transgender individuals, including those who are experiencing stigma and discrimination, so we can really see how these drugs are working in the real world. So although there is hope that ART at younger ages and earlier in the HIV disease process and with less toxic ARVs will lead to a lower burden of morbidity in adults with HIV in the future, we realize that those are a lot of very loaded if this happens and this happens and this happens, very high bars to set. But we also know that there are currents swirling against this hope. So first, we know that younger individuals initiating ART at higher CD4 counts will have decades of life ahead of them, and that will intertwine with the challenge of maintaining viral suppression. Long-term viral suppression is challenging, but necessary to protect the health of the individual as well as the population. And we previously estimated that 1 in 3 adults with HIV will experience a transmissible viral load equal to 1,500 copies per milliliter or greater in the first decade after ART initiation. 1 in 3. That risk is different for Black MSM, it's 1 in 2. People who inject drugs, 1 in 2. Black women, 1 in 2. Hispanic adults, 1 in 3. Non-Black MSM, 1 in 5. So virologic failure on long-term ART may threaten the gains that we make by initiating ART at earlier stages in the HIV disease process. It's something we have to continue to monitor. Moving away from the impact of the virus itself or ARVs, there are other risk factors for negative health outcomes that are highly prevalent in adults with HIV and will affect their aging trajectories if they're not addressed. Smoking is one of those factors. Large proportions of non-AIDS defining cancers, myocardial infarction, and stage renal disease could be avoided with the prevention or elimination of smoking. So due to the younger age at smoking start for many people with HIV, we cannot expect smoking cessation to be easy in any population, including adults with HIV, but clearly smoking cessation is necessary to reduce morbidity in people with HIV. And just when you think we got the story figured out, right, we have vaping. Right, which, you know, now when I drive down the street and I see someone vaping, I have to stop myself from saying, don't do it, because I worry so much about this outbreak of serious lung disease that is so highly concentrated in young, healthy lungs, right? It's very concerning to me. These data are old as of today. The CDC updates this information every Thursday. I put this slide together of the talk last night, so I do not have the new data for today. But until very recently, arguments were being made for vaping as a harm reduction tool to move people off of combustible cigarettes and onto vaping, but all of that has really been silenced with this new outbreak of severe lung disease among individuals who are vaping. Now, we don't know the prevalence of vaping among adults with HIV, although I peeked at it in the max. And I think that this is not something we can ignore. This is definitely happening, and I think not only do we need to be concerned in this outbreak setting, but I think as individuals continue to age, including individuals who may be vapors right now at 18, who later go on to be infected with HIV, as well as people who are infected with HIV now, who are vaping, I think that the damage to the lung is something that not even the companies who produce these e-cigarettes know what the long-term outcomes are. So we will have to continue to monitor this, as we know the lungs are an important part to keep healthy as adults with HIV continue to age, and it may be an organ that is a bit more vulnerable. Social isolation. It's not just for older adults with HIV. So a very interesting study that I'm a little bit obsessed with that specifically recruited older and younger adults with HIV to look at social isolation found more disconnectedness among younger adults with HIV than older adults with HIV. And we know how social isolation can impact a number of health outcomes. The mechanisms leading to social isolation in younger individuals may be very different, and we need to further identify and figure out how to address. So from ART initiation at younger ages, earlier in the HIV disease process, and with potentially less toxic ARVs, to the challenge of long-term viral suppression, to addressing smoking, to trying to figuring out this vaping situation, to social isolation and other prevalent risk factors for future morbidity in younger adults with HIV. The goal is the same, to protect the health span of people aging with HIV and reduce the health span disparity in people with compared to people without HIV by delaying or eliminating the onset of morbidity among people with HIV. So our goals are actually very different in our different populations that compose persons living and aging with HIV. So I think we should challenge ourselves to think about new care models for younger adults who are going to be connected to care for a long time in order to receive their ARTs and stay as healthy as possible. Would a primary care physician be an acceptable healthcare home where an HIV clinician moves into a subspecialty role? How do we best leverage this interaction that we're going to have with younger individuals who have initiated ART and will be on it for decades? How do we make sure we're reaching them with smoking cessation, with resources for mental health and substance use? Can we test different types of care delivery systems like telemedicine? All of these questions are questions that I think will have different answers in this population that is now, from the treat all era, aging with HIV. And one final note about this population initiating ART at younger ages earlier in the disease process and potentially with less toxic ARTs. There's been fantastic basic science showing difference in the hallmarks of aging with the hallmarks of aging in adults with HIV compared to those without. In other words, the burning question here was always, what's the HIV effect? But perhaps we need to modify that question a little bit and ask it again. Perhaps we can learn even more about aging with HIV by comparing these younger individuals who are initiating higher CD4 counts, less toxic regimens, to individuals who did not. What can we learn there? And then finally, this last group of younger individuals who are late to start ART as we wrap up. We must remember that even in research-rich countries where ART is available, stigma and societal barriers keep people from accessing care, as described by a clinician during his fellowship training at the Ponce de Leon Center in Atlanta, which sees 100 AIDS deaths every year, now, today. Worldwide, there are still too many people without access to antiretroviral therapy, and the chance of aging with HIV among those individuals who face these barriers is low due to the low survival. So as a community focused on understanding aging with HIV, we must continue to advocate for a reduction in barriers to care and treatment and a focus on these individuals who are getting left behind through these ending the HIV epidemics that are happening both at the city and the country levels worldwide, so that this group of individuals can also have the opportunity to successfully age with HIV. So in summary, we have different populations swirling here, and we have to know who we're looking at in our studies, and we have to think about the questions we're asking of each of these populations and how the answer could be different across these populations. So with that, because I'm 3 minutes over, thank you for your attention.